Hello, I'm Dr. Jonathan Levine, host of Case Bites, where we unravel the complexities in dentistry from simple to complex cases from a treatment planning case presentation standpoint. Let's get started. So excited to have Dr. Rick Roblee, orthodontist from Fayetteville, Arkansas. Rick Roblee wrote the book, I hate to say it, on interdisciplinary dentistry. My good friend, our colleague, amazing clinician, has the blessing of practicing with his two sons who are also orthodontists. They're very involved with the connection of oral health and overall health, with a deep focus on airway, on sleep, on multidisciplinary dentistry, on moving teeth and moving jaws. So interesting. We like to call him Dr. Pearl because he's always given us the pearls, but he's really Dr. Roblee. Dr. Roblee, you take it away. Case Bites.
Thank you, Jonathan. I'm flattered to hear what you're saying, but certainly don't deserve that. I'm learning just like everybody else. But this is great. You know, we love interjecting the legacy of the interdisciplinary approach to where we are now with virtual and even as much as virtual reality. So what I want to do is just kind of present some good basic information. Obviously, we can't teach too much. We just kind of give examples. But I want to give you an example of a classic case that we all get. You know, one of your best referral sources wants you to treat his son-in-law, and you want to do the very best. And so, first of all, I want to welcome you to Fayetteville, Arkansas. We're here in the fall. This is actually just the other day. You can see the most famous landmark in Arkansas, Old Main there. But let's jump right into this case because we're going to show you Nick. Nick is 39, just a great person. He's a big teddy bear. You can tell he's a large person, not overweight, but just big boned, healthy, a teddy bear type. And his chief concern is, I want to make my teeth match the rest of me. And, you know, that has to happen. And that's part of the art of interdisciplinary aesthetics, is to match the dental health and appearance with their overall physical morphology. And certainly we take a look at him and we can see why he's so concerned. He's got, you know, he's a large person, but he's got very small teeth, microdontia. Also notice he's got extremely hypertrophied masseters, and he's also having headaches and all the typical problems associated with what we consider possibly airway problems and certainly myofunctional type problems. We look at him, he's got a big, strong jaw that actually overpowers his dental alveolar complex. So he's got a very flat lip support. And these are all things that we need to take into consideration. And when we look at his teeth, again, small teeth, everything's collapsed, very narrow. We can see the scalloping on his tongue. And very important, a very unstable traumatic interincisal relationship, which is the key to a lot of this here. We want to focus on the small teeth because we are all dentists and we want to fix teeth, but we need to focus on everything else first. In fact, I like to look at the teeth last. And this retroclined relationship can lead to all kinds of different problems far beyond just wear. We look at his panorex, you know, very healthy dentition, no restorations, takes great care of his teeth. He has 3 remaining third molars. One was extracted previously. But when it comes to those retroclined bite, he has what many people refer to as mandibular entrapment, constricted bite, as John Coyce would say. But what's going on here is every time he bites down, he slams into that traumatic relationship and has to force his jaw back. And on top of that, he has a small airway. And we know he's having episodes of clinical sleep fragmentation during the night, where he's getting shots of adrenaline all night. He's clenching his teeth, and that's why he's got such big masseters. And so let's look at him again. and try to point out a few other very important issues. Again, he wants bigger teeth, but we have to be healthcare professionals that treat the entire person. Lips in repose, he shows, you know, a little bit excessive for his age. He should show maybe 1 millimeter or 2 less incisor exposure. When he smiles, you know, pretty good amount of gingival display, pretty good symmetry. He's a little bit super erupted on the left side, but this is a great view of his scallop borders of his tongue, which is telling me he doesn't have enough room for his tongue. He's a big guy, normal sized tongue for a big guy, small arches and small teeth. That can be a dangerous combination. Again, narrow arch, dentally compensated narrow lower arch. And he tells us all this. He wants bigger teeth, and he only wants to do it with clear aligners. And so we know we potentially have some issues. And we want to do whatever possible because, again, he's our best referral source's son-in-law. Let's talk a little bit about tooth movement. Then we're going to get into other things. When it comes to I only want clear aligners, this is where we have to understand the physiology and the mechanics of tooth movement, that there's so many different kinds, and depending on what you want to do. And of course, for him, it's going to deal with intrusion, it's going to deal with translation, and it's going to deal with pure root movement to get those teeth back into the bone. And when it comes to clear aligners, these are the 3 factors, the 3 types of tooth movement that clear aligners are the least effective on. So what are we going to do? Very important question. Again, your top referral, we want to satisfy him. We want to satisfy not only in the result, but in the process. And so clear aligners can't handle this case. Does that mean we're going to throw out the baby with the bathwater? No. That means we're going to understand what we call the fundamental components and what is leading to this inadequacy in one of our techniques, and we're going to address the fundamental problem. And so again, this goes back to our fundamental components of dental facial problems, and we live and die by these, and we break things down always as an interdisciplinary team into the fundamental components. And by doing that, we're doing definitive treatment planning on what we need to do to correct it. And we don't have time to go into this, but these are critically important. And when it comes to modern day fundamental components, we have to focus on the airway. And with the airway, we also have to add craniofacial muscles and oropharyngeal muscles into this. So this becomes a very important process because in the bottom line, the way his teeth are retroclined have to do with a lot more than genetics. In fact, genetics have nothing to do with it except for the fact that he has small teeth. The relationships, the constricted arches, all have to do with soft tissue function and dysfunction. Notice when you look at this, that occlusion isn't even, in my opinion, a fundamental component problem. Yet, I feel occlusion is critically important. But the way I view occlusion is it is a categorization of the interrelationship of other fundamental components. So when we say he has a class 1 traumatic functional occlusion, we want to figure out why. Is it dental? Is it dental alveolar? Is it alveoloskeletal? Is it skeletal? And then on top of that, we have to understand how we can treat those fundamental components. And this is where we look at mild to severe malocclusions, and depending on which fundamental component is at fault. And for that, we have traditional therapies that we've used for years. And on top of that, today, we have non-traditional therapies that we can expand our elements. Obviously, we know we're going to be treating him dentally, but how are we going to get the teeth in the right position? How are we going to overcome this traumatic occlusion? And how are we going to fill out his face and his lip support to maximize the overall aesthetics? That's the question. And we're going to go back to anthropologically driven function, structure, and behavior in almost everything we do. And so again, looking at his traumatic malocclusion with the small teeth, he only wants the clear aligners. And so this is where he is, and we have to break things down into what we consider his malocclusion range. He's got heavy dental counterparts with the microdontia. He has dental-alveolar, which is the relationship of the dental-alveolar complex and of the teeth in the dental-alveolar complex. And he has alveoloskeletal problems, which is the relationship of the dental-alveolar complex on the skeletal base, which is totally retrusive. And so to correct this, we know we're going to do restorative to make his teeth the correct size, which is absolutely a genetic problem. But to do this, we're going to have to do orthodontics to move the teeth forward. And since he wants clear aligners and we don't want to disappoint that, we have to treat the infrastructure to not only allow clear aligners to overcome their inadequacies, but to overcome the alveoloskeletal problems. And we're going to do this with corticotomy SFOT, okay? And so his interdisciplinary treatment plan is going to be pre-restorative surgically facilitated orthodontic therapy. We're going to do selective corticotomies with hard and soft tissue grafting. We're going to do osseous recontouring with aesthetic crown lengthening to establish ideal height and width ratios. And it's obvious part of his small teeth are genetic and part of it is periodontal. And it has too much bone close to the CEJ, which is leading to too much soft tissue covering. We're going to do clear aligner therapy, which now we can do effectively because we're going to reduce the resistance in the bone by over 50%. And then we're going to do all the beautiful lab work, minimally invasive intra-enamel preparations, and labial veneer restorations to optimal anatomy. So how are we going to do that? Well, first we're going to go back again to the fundamental components. And we always treat to the CEJ. We don't need guides to talk about where we need to do the aesthetic crown lengthening because we're going to treat to the CEJ, which is always the best to treat. And we need to know and understand the anatomy. Why do we treat to the CEJ? Because we want to treat that structure ideally, knowing that if we still have a gummy smile, we can easily orthodontically correct that alveoloskeletal problem, okay? And we're going to use all the literature. We're going to use the Starrett study to analyze the proper teeth for him. And we have different forms that we go through to decide what teeth are the right shape and size and what sizes we need to do. So here's initial malocclusion. This is looking at his Bolton relationship. And you can see a guy like this should easily have teeth at least 1 millimeter or more widthwise. And then, of course, we have to restore the proper form. And very important here, we can use the rule that is so important where the centrals are X, the laterals are X minus 2, and the cuspids are X minus 1, and start working mathematical capacities to work this case up. In this case, we didn't need to do a digital smile design because he was already sold. We didn't have to do any motivation. And so we just worked it up ideally. Then surgical facilitation. And we're going to go ahead and do the corticotomies with all the literature that we have. And here are the corticotomies. And again, looking at demineralizing the bone, not only is this going to help us move the teeth with clear aligners, it's going to help us to expand the dental relationships far more than we could with traditional therapy. And when we look at, again, the size of the teeth, here's our clinch check. Here's the initial result 3 months later. It took us 3 months to get here. Now look what happened. We changed the dental-alveolar components. We changed the periodontal components as part of that surgery. And we've also changed the alveolo-skeletal by increasing to a much greater volume. So much to the fact that when you look at this, look how much we've increased the width of his arches, almost 6 millimeters intermolar resistance. Now we see the spacing initially. We have greater oral volume. We can see the difference in the tongue room. We can also see the healthier periodontium to a much more stable relationship, treating to the CEJ. Then we start doing the restorative, using guides to do optimal reduction in the high spots, and then we do minimal preparations for optimal restorations. And here you can see the initial, the post-ortho, and then the final. Smile. Notice how the teeth are decompensated. Notice the post-restorative, and he picked a much wider shade than we would have cared. And here's the final relationship. Notice how much fuller his arches look. Notice how much fuller his teeth look. Notice how now his teeth fit the size of his face and the rest of him. Notice how also how his face is starting to thin, because we've also treated the underlying airway issues, and he's not clenching his teeth as much. Again, with the final and final facial. And notice how not only did we give him the fuller smile, the size teeth he wanted, but look at how we filled out his lip support, and how through corticotomies, we were able to change the alveolo-skeletal relationships. And so with that is how we treat cases like this, and can treat them not only optimally, but in short time. This case took us, around 9 months of active treatment, and then about 3 months of restorations. I'd love to hear any comments.
It's beautiful. And fundamentally, the patient is going to benefit not just from the smile, but from the approach of taking care of the airway. Has he seen better results with his sleeping, or is he?
Oh, absolutely. Absolutely. In fact, he gave a long testimonial. I wish we had time to show, but just look at his face. Can you see how much narrower his face is? Yes.
Yeah.
Yeah. Mm-hmm. This is where, the beautiful thing about what we do is who else in healthcare can treat major underlying health issues and make people more beautiful at the same time?
Yeah.
I love what we do.
Yeah.
So well said, Dr. Roblee. What a beautiful case. And this shows how just putting the structures in the right place makes all the difference. And then just with the gentle restorative procedures, the patient is completely changed. Beautiful. Thank you.
So thank you. And I think you pointed out something very important. Is we break things down to the fundamental components. And then in the interdisciplinary approach in modern dentistry, especially with digital technology, we can master each of those elements if we have the team to do it.
How do you follow up with retention on a case like this?
Okay, first of all, he's going to need, this guy's going to go through sleep hygiene, which is basically myofunctional therapy, teaching him how to breathe through his nose for the first time. And that's where we start looking at tissue ties and other things. And we're just going to give him basic retention, a lower bonded retainer and an upper holly to keep things from collapsing. But we relied a lot on redirecting the soft tissue. And if you get the soft tissue in harmony with what it should be with the new structure, it really adds to stability. Plus, the other important thing is with corticotomies, we're not just moving teeth through bone, we're regrowing the entire dentalveolar complex, which is radically more stable.
I have a question for you, Dr. Roblee, not for this particular case, but in general for your sleep patients. Do you ever use mandibular advancement devices, or you treat strictly by moving the structures?
You mean for sleep issues. Is that what you're saying?
Yes.
Yes. Yes. And I'll tell you what we do mostly, though. We mostly use that. We use the MyTap a lot because our goal, we do a lot of sleep dentistry, but we're not about CPAPs or mandibular advancement appliances. We're about treating the underlying structure and soft tissue to treat and cure the underlying problem, okay? And so we use the mandibular advancement appliances, number one, when the patient refuses any other treatment. But more importantly, we use it to test our hypothesis. If we feel their oral pharynx is small, and we know that by opening it up, by giving them more oral volume, that it might help, we can test that with the MyTap and as a mandibular advancement. And a lot of patients that come in have pretty significant apnea, we test them, we work with their physicians, and then we can reduce that down to maybe as a retainer. Now there's some amazing, milled, virtually designed and milled mandibular advancement appliances that make great retainers. And so we use that to get them the rest of that way to the end zone.
Yeah. Just echo that. Yeah.
Follow up. Sorry.
No, I just wanted to weigh in, and as on the specialty team on our end, we're using the mandibular advancement appliance as an initial therapy, especially when you're looking at an upper airway restriction. So through the CBCT, we could see the airway. So if they're breathing through a straw and they got 47 millimeters and less and 50 millimeters and should be 130, 140 plus, there's a constriction. There's some type of URS, upper airway restricted syndrome. That does very well with the mandibular advancement appliance. And at least it's a phase one to get started. Mm-hmm. This collaboration of interdisciplinary, where everybody has their unique ability and they bring it to the table. We learn so much from each other, and really the magic here is to tell our profession, find your specialists and work together. And like the old days of Spear, Kokich, and Matthews, who wrote those amazing first interdisciplinary conversations, probably Rick after they read your book, but there have been pockets all over the country for 25 years doing this. And now this really has to be mainstream. And that's why I'm so excited about this conversation with Case Bites, is how much we can learn from each other through our own unique abilities and our own capabilities. Is anybody like to close?
I'd like to say that was an excellent case, Dr. Roblee, where you exhibited excellent interdisciplinary care, even within the realm or world of periodontics. There were a multitude of procedures done to make this procedure work out the way it did, and so successfully. And at least in North Carolina, in my area, I feel like what's really underutilized is the selective corticotomy with the grafting to help facilitate accelerated orthodontic therapy. I think should be used more often. Who wants to have prolonged therapy? And for me, just looking at, as I do a lot of implants, I'm doing CT scans on every patient I do. And when you do these CT scans on people with history of orthodontics in the past, I mean, it's not surprising that you see when these teeth are moved more so out of the alveolar housing, and you see the dehiscences and the fenestration and all that is present, and that necessitates more grafting for when you do implant therapy. When you do the selective corticotomy, I mean, you have that liberty and freedom of moving teeth, because when you do the grafting, you're going to have that thick phenotype. You're going to have adequate volume of bone that you don't have to worry about at the time of therapy. And God forbid if something happens later on, I mean, they're going to have adequate bone likely in the future. So this was a great case to show. I thank you for that.
Thank you. And again, it goes to treating the problems. And the perio was part of the problem. And if you looked at the health of his tissue after we finished, it looked even better than before. And we were literally 3 to 4 millimeters more facial. And so it's a different ballgame. Yes. Thank you very much.
The amazing thing is that with our knowledge, and both in all of healthcare, medicine, and dentistry, we are now really going to be able to connect the dots between our disciplines. And this is a perfect example, tip of the spear of dentistry, connecting oral health and overall health, and why what we do, it's so important to keep expanding our knowledge and learning from each other. I'm going to always come back to that. It's amazing collaboration. Amazing collaboration.
If I may ask one more question to Dr. Roblee, in regards to the mandibular advancement devices, do you have any secret of how you maintain the tooth position with those devices?
Yes. Yeah, that's really good. And yeah, this is a great conversation. I'll keep it condensed. But you need to have a really good fitting one. That's where these new digitally milled ones out of one solid piece of plastic are the best retaining. The teeth aren't going to move. Okay. Now the other part of that is you need to have an AM aligner that they put in to force the jaw back. Now the other part of it is some people are going to all of a sudden end up with an underbite. And I promise you, if you look at your initial records, those are the people that had a constricted bite that were trapped back. And they've adapted where they should adapt, okay? And you can see now that the problem is a deficient maxilla. And that's a perfect indication then to go do SFOT and move the maxilla to where the new mandibular position. So that's just a quick, snippet on that. But anyway, it's all critically important, but it's understanding the fundamental components and how to address each one ideally. That's the key to the interdisciplinary approach. And one more thing is there's no magical interdisciplinary team that you're going to join. You're going to have to grow your own. And that's really important. And hopefully this series is going to help everybody do that.
Thank you very much.
I think so. And that's a great note to leave it. Let's try to galvanize our profession, and we can just hopefully be additive to this concept of working together, working collaboratively for the good of our patients, and keep learning and keep growing with our knowledge. Well, that wraps it. That wraps it for Case Bites. That was a great session. Thank you, everybody. Thank you, Dr. Roblee, for presenting. And we'll see you all real soon. Thank you. Thank you for joining us for Case Bites. If you haven't already, please subscribe to this series to receive a new case in your inbox every week.